Ooh, yikes. Let's clean that up. No, come on now. Okay, hey guys, this is a video I want to make you to help you with writing your charts. I know you guys need to do them, and we're historically pretty terrible about providing this direction. So I want to do it here. So I'm going to write this out for you along with explaining this. So let's talk about the different methods. I'm not sure exactly which one they're saying that you got to do, so I'll go over both of them. But I believe it's SOAP. So let's talk about SOAP, the SOAP format. And these are guidelines. This is going to help you get started, and you can spend your entire careers modifying this as you want. So let's talk about it. So the S stands for subjective. And this is what the patient tells you, all right? So we can put some bullets here. So this is going to be the chief complaint. It's going to be the first thing you're going to say, hey, what's going on? And they'll say, oh, I can't breathe, or I'm having some chest pain. So that's the chief complaint. Under subjective is going to be the history of present illness. And this is using that mnemonic, right? We have one of those. We have the O, and that's the onset. When did this start, and what were you doing when this started? There's P, provokes. Does anything make this complaint not just pain, but you can do it for difficulty breathing, you can do it for nausea, whatever you want. Does anything make it better or worse, right? It's not always applicable. Not all these questions are always applicable, but a lot of times they are. Okay, quality or description. Can you describe how it feels, right? We can use that not just for like chest pain. That's the most common one. But we could do it for something like difficulty breathing. I'll ask people all the time, like, does it feel like you just can't get a good breath in, or does it just feel like it's really hard to breathe, or like you just can't catch your breath? I'll give them options. It'll help them. Also make sure that you differentiate between pain and pressure. Because I had it with my trainee the other week where she asked this woman if she was having chest pain, because we were called initially for chest pain. And the woman said, no, I don't have any pain. My trainee kind of shut off to the idea of pain when she heard her say that. And I heard my trainee kind of say something to her at the same time that the woman said, but I'm having pressure now. But my trainee didn't hear it. I heard it, but my trainee didn't. And I was waiting to see if she'd caught on to that. And I kind of keyed her into it later on in the call. So people will they'll be very specific whether it's pain or pressure. You got to make sure you ask for both. I ask about any discomfort. It's a blanket term. R, radiates. Do you feel this pain or other pain elsewhere? If you're having a hard time breathing, do you have any pain anywhere? Right? S, severity. And I want to take 30 seconds to explain this. I hate asking, on a scale of 1 to 10, how would you rate your pain, 10 being the worst? I hate that, because in 10 years of doing this, very few of my patients have ever said, oh, that's a really good question. Let me think about that. They say, well, how the heck am I supposed to answer that? So my approach to this question is, when I get to the patient, I'll say, okay, you're having pain. If we could rate the pain that you're experiencing right now a 5 out of 10, how would you rate the pain when it began? Would you rate it a 1 being very little pain? Would you rate it a 10 being a whole lot of pain? Would you rate it at the same level at a 5? That way we provide them direction with how we want them to use our tool. A lot of times we just give them the 1 out of 10 scale, and we don't tell them how we want them to use our tool. And again, the biggest reason we use this tool, the severity tool, is to help determine if our treatments are actually helping them, right? So if someone's having chest pressure, for instance, and we give them a nitro tablet, and a few minutes later, we want to know if that pain went anywhere, right? And we want to know by a certain degree. Obviously, this is very subjective. It's falling under the subjective, but it really does help us. But that's why we ask it. And then T, time. And this can be, has it been constant pain or intermittent pain? It could be gradual or sudden onset. You could even say that up at the onset as well if you want. But that's kind of what we're asking about time. Okay. And underneath this, we will ask about past medical history as well. And this is the allergies, medications, medical history. You can also add last oral intake, although this is more applicable in like abdominal pain, nausea, vomiting, diarrhea, something like that. Diabetes. Jillian brought that up today. That was really good. And then events leading to the incident. This could go in there as well. And this could be just more of an overall summarizing of what the patient's reporting to you. All right. So that's all going under subjective. Okay. So let's talk about the next line down, and that is the objective. That's the O. Stands for objective. And this is going to be everything that what you assess, what you observe. And this is going to be things like your general impression. Patient. Helps if you spell right. This is going to be like age, gender, position. This goes a long way in determining how they're doing. Position and location. Level of consciousness, orientation, and behavior. So if they're alert, are they alert and oriented, not orientated, oriented, and what's their behavior? That goes a long way. And I stick, in my own report, I stick in any neurologic deficits I see, like speech, facial, extremity. That's under your general impression, right? Okay. And then under this, we also do our physical assessment. And this is some stuff like their airway. Is it open, controlled by the patient? Their breathing. Rate, quality, and that is, let's see here, and then skin, other way, and then circulation. It's going to be radial pulses. I described those. Skin, color, temp, condition, and then trauma or bleeding. All right. Breathing rate and quality. Now, it's kind of hard to describe the quality. You could say it's normal, but normal doesn't really tell us much. You could say breathing is non-labored, labored or non-labored. Supports speech. What kind of speech does it support? Full speech or dyspnea? Like 1 to 2 word bursts, right? Okay. That's going under our objective, right? And the fun thing about this, here's a way that we can kind of kill 2 birds with 1 stone, is if you look at your medical/trauma assessment, hang on, let me pull it up here. There we go. If you look at your medical/trauma, your patient assessment, medical, patient assessment, trauma, it's the exact same thing from the scene size up to the identify your priority patients. And look at what we just did in our objective assessment of the patient. Well, pretty much everything in the primary survey went under objective, right? And in that order, right? So you could say, and I'll write this out in a minute. Gosh, 9 minutes. I've gone through this video trying to cut the time down like 8 times, and I just can't. So I'm just gonna get through it. And so that's your physical assessment, and then you can do vitals. And so make sure you document the time, and then make sure you take your BP, heart rate, respiratory rate, pulse ox, and this can be end-tidal, CO2. It can be gel if you take a blood sugar. It can be a temp. We're taking a lot of temps these days. So vitals, make sure, and you need a trend, right? So you don't just take one set, you take multiple sets. And you document what time you take them, because that shows you any changes. You can also put their pain number, their pain rating in that too, to see if the pain has changed, right? Because a lot of times we take vitals after we give medications. Okay, oops. Next one down is your assessment, A, assessment. And this is going to be your physical assessment. Now you can look up other methods of this, but this is pretty much your physical assessment. And you can switch, organize it however you want. You can do the head, neck assessment, torso assessment, and that is the chest and back. Keep in mind that the chest is just the anterior part of the torso. The back is the posterior part of the torso. Whatever stuff lives on the front or is affected by impact to the front of the chest is the same as impacted by the back, right? Like the lungs, right? Abdomen and extremities, and then you can do spine, right? Now you don't have to do that for every single person. You could maybe alter this. So like with the kid with the cuts to the arm, the superficial cuts to the arm, that would definitely be an extremity assessment, right? Oh my gosh, got 4 minutes left. Jeepers. Okay, and then P is your plan, and this is your treatment plan for the patient, right? So what are you going to do for them? And you're going to have, you could organize this in on scene, right? And during transport. And then transport mode and destination. Did I spell that right? No, I did not. Destination. Got it. So that's basically what we will do for the SOAP method. So let's write this out with this guy. Let's do this. I got 3 minutes left. Let's see if I can get this done. 3 minutes. So we're going to do let's do the suicide. So let's go ask the subjective part, right? So patient reports he's feeling increasingly depressed and suicidal. Patient reports he cut his wrists today to harm himself. All right, so there you go. There's the S. Or there's part of the S. That's what he reported. So that's his chief complaint. Oh boy. See. All right. You know what? I'm gonna think this through a bit better before I go writing it. But that's what I got for you in terms of the SOAP method. I'll do another video where I'm gonna actually write this out and I'll practice it a little bit more. But that's what we got. I'm gonna post this and see if it helps you guys. All right. Again, email me if you have any questions about this. I'd be happy to go over it, and I'll make a few more videos if you guys would like.